Everybody, greetings and warm welcome to all the delegates, faculty members, friends from the pharma industry. Thank you for having taken out this time and having made this JICS second edition possible. It also gives me a great sense of satisfaction and accomplishment, to see everybody here today. We stand at the forefront of a new era in healthcare, where innovation, technology, collaborations, and compassions converge. And JICS has gained stupendous popularity among intensivists, among postgraduates, and amongst trainees. And as healthcare professionals, we are united by a shared commitment to improve human health and well-being. So let us all embrace this opportunity to learn from each other. Let us foster a meaningful connection and leave a lasting impact on the life of patients and community at large. I welcome you all to enjoy the scientific content, to enjoy the deliberation by our esteemed faculties, also to enjoy the gastronomical delights that are going to be churned out by our chefs in the next couple of days. I now like to declare the JICS second edition open. Thank you all.
Thank you, Dr. Farooq. I would now request all of you to kindly stand up for a small prayer.
Hari Purusha Namaham Bhajami Govindam Hari Purusha Namaham Bhajami Govindam Hari Purusha Namaham Bhajami Marhabatam Samaksitam Buddha Sundaranam Kandar Agom Vigamaniya Vishesha Shobha Govinda Hari Purusha Namaham Bhajami Govinda Hari Purusha Namaham Bhajami Govinda Hari Purusha Namaham Bhajami Angani Asa Sakale
We will start with our sessions. The first session is a very interesting topic, emerging concepts in critical care. I would like to invite our chief moderator, Dr. Padma Kumar A.V., who is a senior director in Department of Critical Care Medicine, Fortis Hospital, Bangalore, to the dais. I would also like to invite the chairpersons for the session, Dr. Anil Kumar T., Professor and Head, General Medicine, Saptagiri Institute of Medical Sciences and Research Center, Bangalore. Dr. Ayappan C., Consultant and ICU in Charge, Critical Care Medicine at Apollo Specialty Hospitals, Madurai. Dr. Simant Kumar Jha, Senior Consultant, Department of Critical Care Medicine, PSRI Hospital, Delhi. Dr. Raman Muralidharan, Senior Consultant at Baby Memorial Hospital in Calicut. Dr. Narendranath Jeena, Director and Head of Institute of Emergency Medicine in Meenakshi Mission Hospital and Research Center, Madurai. And Dr. Chandrasekhar from KR Hospital, Bengaluru. I would request Dr. Padma Kumar to take over.
Thank you, Dr. Pradeep, and all the organizers of the JICS 2024 for giving me the opportunity to be the moderator of the first session of this program. I would like to invite Dr. Vinila to start the session. She is Director of Critical Care in Vellore Hospital. And the first topic is humanizing the ICU and beyond, HEAL ICU. When you think about the ICU, we generally think that all patients are on ventilator and patient is getting dialyzed. And something what we miss out is the human touch, which previously we used to get from all doctors. So all the technology has changed, and what we can see is that after COVID, actually the human touch is completely disappeared. So I would like to hear from Dr. Vinila how we should get better and what we can do. Because as time passes, technology is going to take over, and I can hear a story that there was a robo was sent to a patient to declare that the patient is not going to survive. It happened in California. So I would like Dr. Vinila for the first talk.
Thank you, sir. I'd like to thank Dr. Pradeep and the organizers for inviting me to give this session. A couple of weeks back, I had a chat with some of our registrars as to what they understood by the concept humanizing ICU care. And a few of them brought out terminologies like recognizing patient identity, maintaining patient dignity, respecting their wishes, okay? But I think medical humanization is a bit more than that. It's acknowledging the emotional and psychological needs of not just the patients, but also the families and the healthcare workers. Now, this is definitely not, in the true sense of the word, an emerging concept. It's been around for about a couple of decades right now, and very much in the picture from 2014, especially by the Spanish group who came about with a project called the Proyecto HUSI, or the Project HICU, or Humanized ICU. So it's been around for about 10 years. So why are we so concerned at this point of time? I think the main worry is there's been a rapid rise in technology, medical advancements, all of which have been reported to have a negative impact on patients, as Sir mentioned, in terms of depersonalization. Families feel dehumanized. In addition to this rise of technology, we can see here, this is a paper which has been recently published in the Lancet. Dr. Atul Kulkarni was one of the authors. Pre and post-COVID, there's actually a 5-fold increase in the ICU beds in India. So we now have about 10.7 beds per 100,000 population. In order to run an ICU, it's not just infrastructure, it's not just ICU beds. As you can see here, we need a skilled multidisciplinary team. And that is something which is lacking in many places, not just in terms of skill level may be there for some people, but in terms of numbers, in terms of training, in terms of time. So a lot of people, with this lack of training and time, it is understandable that the amount of time spent with patients, the treatment given to patients can be affected. Now, I'm not here to question whether you guys are humane or not. I'm sure all of us try our best to be as nice to patients as much as possible. But I'd like you to think about just a few of these things that you can see here. How many of y'all are guilty of seeing any of these quotes that you can see here? Say that you've admitted an interesting case of sepsis in bed 4. Have you sent the consult for this patient in bed 6? The family of this bed number is difficult. How many of us are guilty of that? I am guilty of that, I know, and I'm sure many of us have faced this problem as well. And in addition, this is a very interesting study which has come about, which actually talked about different mannerisms of medical teams. And you can see here that I'm sure many of us do face this problem, and you've seen our juniors also doing this. You do a procedure, you'll be talking over the patient, especially if they are intubated. You fail to acknowledge that they may be actually able to hear you. And sometimes we don't allow family presence. We have restricted visiting hours. And all of this has resulted in families and patients feeling anxious, feeling scared, feeling distressed, and having a loss of trust in our medical services. So it is very sad to see that the post-ICU syndrome in families is experienced in almost 50% of families. Because of what we saw earlier, because of the way healthcare has been going on, and there is an added burden of guilt and responsibility for the families being surrogate decision makers. Now, this is a study which actually looked at family satisfaction with critical care in the UK. This is one of the largest studies which has looked at family satisfaction. They used a very well-validated questionnaire called the FS-ICU 24, in which about 7,000 participants were there of family members who survived and where the patient survived and did not survive. Now, this FS-ICU 24 has three main domains. It covers care, information needs, and decision making. And in the study, it was heartening to see that actually they scored very high in all three domains in terms of families actually feeling cared for, information needs being met and being helped in decision making. And what was even more heartening to see is that the families of ICU non-survivors were far more satisfied than the families of survivors, which is probably what we also face in our situations, because we do spend a lot of time with families who we don't expect to see surviving. I think the most important is the healthcare professionals. We tend to forget the healthcare professionals who, if, many of us who are working day in and day out in ICU sometimes tend to form a protective shell around ourselves. We do that to protect ourselves and to help us carry on dealing with death, dealing with difficult situations, and hence we have that kind of an emotional disconnect with patients and their families. This is, I think, a mechanism of preventing burnout and moral distress. So what are ways in which we can improve humanization in the ICU? The Spanish group actually brought about this multifaceted approach to medical humanization, and they've got this very colorful chart which looks at 8 different domains. I'm going to put this chart in a different form, again focusing on the 3 main groups that I talked about earlier, that is the patient, the families, and the healthcare professionals. Now to me, actually, I feel the healthcare professionals are the main group that we need to target. You don't take care of the healthcare professionals, then sorry, there's a little bit of a problem with you don't take care of the healthcare professionals, don't take care of their needs, don't understand how much of burnout they face, how can they give the care that is needed for the patients and their families? With regards to patients, I think all of us need to focus on communication skills. It is important that as faculty, we introduce ourselves, we talk to patients, call them by name, because a lot of our juniors actually see and replicate what we do. Our focus should be on the well-being of the patients, the physical, psychological, spiritual well-being of the patients, and respect the patient autonomy. As far as possible, we should try and make sure that our ICU is as friendly as possible to help the patient orient themselves to day and night as much as it's possible, and to work on ways of preventing the post-ICU syndrome. With regards to family, I think, again, here, communication is key. And in order to facilitate communication in our hospital, we have found in the ICUs, having skilled social care workers actually helps in communicating with families. Having an open visitation policy, I'm sure many of you will be having, positive and negative thoughts about the open visitation policy, where you allow patients and the families to come in beyond visiting hours, and making sure that they participate in some of the procedures related to patient care, and you help them in their decision making. Now, the next few slides, I'm going to show you some pictures from CMC of what we try and do to make the journey as humane as possible for the patients and the family members. Now, if you can see here, you can see that we've got a name there which I blocked out. We've got, in bracket, I have what the patient likes to be called by, and also the language. Now, the language is something which we added on newly, because earlier we used to think that this patient probably understands Tamil, start speaking them in Tamil, and then we realize they're not responding because they speak Hindi. So this is one way in which you can actually help in making the patients feel a little more at home. Here you can see this patient listening to music, which she enjoys as per the family's opinion. And we also intermittently, when patients get well enough, make them sit so that they can see the sunlight and feel a lot better. These are pictures from COVID times. I'm glad Sir mentioned COVID times. Where we struggled with not having family members around. And you can see here that we've actually hung a lot of pictures of family members around the COVID patients to make them feel at home. These are things which we don't do in CMC here, but there are some areas in India which do use ICU diaries. I don't think we've still reached the point of having pets in the ICU yet. And get to know me boards where you get to know the patient a little bit more in terms of their likes, dislikes, what they would like to do, what they like to be called, their interests, their hobbies. All that are other ways in which we can make the patients feel more humane. I personally also feel that restraints, physical restraints, that is something which I absolutely dislike. That is something which both the patients and the families, I think, will remember for years to come. All of you would have heard about the ABCDEF bundle for delirium. Now, the same authors have added a GHI component, where G stands for gaining insight into patient needs, H stands for holistic and personalized care, and ICU design or ICU design redefinition. So now this again is focusing on the humanized approach to patient care. When you look at the family members, it's good to have a separate isolated area for counseling. And as I said, we have social workers who are trained people in communication who are regularly communicating with the families. It's important to make the families feel like they're taken care of, have a good waiting area, bathrooms, drinking water, dormitories for other family members if it's available. Now this is, I have to be very frank, all this is possible in CMC only after the new hospital came about. And I think when people are planning new hospitals, these may be things which can be looked at. We also involve family members in patient care. I would just like to present the same audit, an audit using the same tool which I mentioned earlier on family satisfaction, which is the FS-ICU 24 tool. And sorry, I think this didn't come properly here, but then essentially this covered, one of our registrars actually interviewed family members on day 3, day 10, and day 20 of their ICU stay, just to get their perceptions as to whether they were satisfied with care. You can see here that in all domains, whether it is care, related to information provision, related to decision making, most of our families were happy. But very interestingly, I've just put this as it was written down by the family members. When we asked them how we could improve, they actually, even though we think we have an open visitation policy, they actually put down we need more time with the patient apart from visiting time. So sometimes we feel we're doing a good job, but the family's perceptions may be different. So I think it's a very good idea to find out where you are in your hospital, in your ICU, as to what the families actually feel about the humanity and the humanization which is there. Now there are a lot of evidence which is very low quality, modest evidence which is there for family-centered care in the ICU. And there's so many areas which can be targeted, but I think it's important to decide which interventions actually make sense for your ICU, and it should not be at the cost of clinician burnout. Now, looking at healthcare professionals, it's important to train healthcare professionals in communication skills, ethics, and good clinical practices. The best way of training is by making your registrars actually sit down with you when you have a family meeting and a discussion. They learn from you because you are their role models. Debriefing sessions for staff after difficult decisions, and also dealing with difficult ethical situations. There's so many times when we ourselves don't know what to do. When you have a if it'll be good for hospitals to have a hospital ethics committee which can actually help guide and the team in deciding what to do for a patient. This is a very interesting study from the US and Canada. Now, in this study, young residents who were facing patients who were end of life, going through end of life. This is a 3 wishes project where patients were actually, families were given the option of 3 wishes for their loved ones. What would they like their loved ones to do? That is a different aspect to this, but I just want you to highlight on that box which I've put there. The residents actually felt helpless. They felt that their education was inadequate, and they felt that this was a skill which was valued. Now, this was in Canada, where I think the medical students' burden is less. Here in our country, with NEET and all the other exams which are in place, I think this is definitely an area which needs to be focused on in much more detail. In addition, now I think healthcare professionals, we all work in the ICU day in and day out, tirelessly, hard work. I think it's important. A good way is to get out, have some fun, go for some picnics, have some light-hearted moments that actually helps prevent burnout and moral distress. Now, coming to the last few slides, in terms of challenges to humanization in the ICU, I think all of us who work in ICU say, how can we be humane? Like ICU is so fast-paced. We have to deal with so many sick patients. How can I, be resuscitating a patient and then going and showing a lot of love to the family members? It's difficult. We are also facing defensive medicine. There's so much time which is spent in documenting, getting consents. Everything becomes like, more paperwork that we are trying to protect ourselves because medico-legal cases are going up. These are all challenges to humanizations in ICU, not just in our country, but everywhere else. In India, we know that, as I mentioned earlier, humanization is a bit of wishful thinking. We do have a compromise in the number of staff, in their training, in the time that they, for training and the time that they spend with the patients in ICU. There are several language barriers as well, and the open visitation policy can actually disrupt patient care. I'm sure most of you would have seen this. This is from your Bangalore only, where a person was actually greeted by a virtual receptionist. And that is probably what we're going to see in the future in ICUs, virtual doctors and nurses with tele-ICU. So I think the thing is, will the situation actually become more impersonal, or will this give us actually more time to interact with patients and their loved ones? So we have challenging times ahead. We should be sensitive to the matter. There are many things which I've discussed, which I'm sure are in place in your ICUs, but do the patients and families actually feel humanized? Do we actually care? Do we actually show that? We need to know where you stand. Please do some audits in your ICUs. We need more research in ICUs to understand what the perspectives in India, the challenges, the perspectives in private and public hospitals. And the most important thing is training. We need to train our healthcare professionals and prevent staff burnout. So I'd like to end by saying that I know in many conferences we have personalized care of sepsis, personalized care of ARDS. This is the era of personalized ICU care. I just want to urge each one of you to personalize your care. Thank you.
Thank you, Dr. Pinilla, for an excellent lecture. So I have got one question for you. Basically, see, we had an open ICU with an open policy to visit. We never used to restrict anybody. Have you had any challenges because we always allow the patient relatives inside?
So definitely the open visitation policy has its pros and cons. While families actually feel that they're free enough to come in, for the staff, I think the problem is felt by the staff and the healthcare professionals within the ICU, because they have to work around the families who are within the ICU, and that causes a lot of unhappiness for the staff, makes it difficult for them. But I think from the family perspective, they like it. Healthcare professional face a challenge.
Yeah, I fully agree with you, because always the issues is with the nursing staff, because they won't be able to perform what the routines, what they do for the patient. And are our Indian mentality, or because I know that you also might have worked abroad, so you know that nobody interfere with anything. But is the same policy is applicable to Indian population? What you see in the West?
Sir, I didn't get your question. I couldn't hear you very clearly.
No, because the Indian patient relative, there is not only one relative. You will have 15 relatives wanted to visit. If you see in the Western population, basically they know that the patient is in the ICU. They will never want to disturb anything, and they believe the doctor what you do. You don't even ask who is the doctor. So here every relative wanted to see the doctor. That is because in relatives there is no limit. Even if you have got a friend, you tell you are a relative, because you can't just verify who is the relative.
Yeah, that's true, sir. I think definitely we need to find the right balance. That is where we need to, each hospital has to find what balance works for them.
No, the question is that our society is mature enough for an open visiting policy?
Actually, in CMC, we have an open visitation policy.
And you are able to manage?
We are able to manage for the moment. Definitely when there is some major activity which is happening within the ICU, our security don't allow family members to come inside. So.
Yeah, security is another issue. That is a different issue. I don't want to take it up now. I think we wanted to do the next session, because question and answer we'll do in the last. I would like to invite Dr. Srinivas. Srinivas Samavedan is the head of the Department of Critical Care and medical director of Vinci Hospital in Hyderabad. His academic achievement is he is a gold medalist in internal medicine NTR UHS in 2000, special interest, artificial intelligence, quality and economics in ICU. So interventions that improved patient outcomes in the recent advances in last 5 years. Please, Dr. Srinivas Samavedam.
Good afternoon. It's always a pleasure to be here in Namma Bengaluru, and I thank all the men in black sitting in front for inviting me for this program yet again. The next 14 minutes, I will try to speak about what interventions have probably influenced patient outcomes in the last 5 years. I have no financial disclosures to make, nor do I have any conflict of interest. But what I can say is what I'm going to speak is entirely my perceptions, may differ from those of you who are listening to this talk. Where exactly has the change happened in the way we are handling patients? If I can think in the last 5 years, the paradigm shifts have essentially been in the fields of fluid therapy, some aspects of mechanical ventilation. New paradigms have emerged and new entities have probably helped us in personalizing the prescription of mechanical ventilation. So also our understanding of oxygenation and the oxygen targets which we set for our patients. Point of care ultrasound has revolutionized the way we approach the common problems in intensive care, and catheter guided therapies have also probably made some difference into life-threatening problems which we face in the intensive care unit. As has been discussed in the previous talk, family involvement in decision making, family involvement during critical illness has also probably been a paradigm shift which has worked in the patient's favor. What exactly is this change we are talking about? We are talking about fluid stewardship. We are talking about the role of balanced fluids and how to balance your fluid therapy. We are looking at conservative oxygen targets with individualized prescriptions. We have progressed from the era of tidal volumes, PEEP, and plateau pressures to the era of mechanical power and transpulmonary pressures. We also have been able to learn the skill and art of assessment of emergency situations with the judicious and timely use of point of care ultrasound. And we know that catheter guided therapies have begun to play an important role in improving the outcomes of patients with acute ischemic stroke and venous thromboembolism. First, we'll look at fluid stewardship. We have understood over the years that fluids are drugs and they need to be prescribed, but it has now become a complete paradigm. The 8 pillars of fluid stewardship, we treat them as drugs. We have a dose for them, which means for how many hours, how many times, or what is the dose you give, how do you monitor the therapy, when do you want to de-escalate, and what is the optimum duration of fluid therapy. So these 8 pillars of fluid resuscitation have become an integral part of quality assessment in intensive care practices. Those of you who audit your outcomes probably would be looking at your utilization of fluids on a monthly or a quarterly basis. So this has slowly evolved into the 7R approach for the use of fluids. So you know how to resuscitate patients. Of course, the Surviving Sepsis campaign gives you a number, but that may not be applicable to all patients and some may need more. Boluses, how much do you give? What exactly is a fluid challenge? We now know in a very scientific way. We know what is routine maintenance and how to replace fluids in what situations. Nutrition and how to re-energize your patients. How to balance your drug dilutions, and how to manage the redistribution of fluids when the patient ebbs and flows during the course of his critical illness is what we have learned. So fluid therapy and the stewardship has probably been the most important change that has happened in the last 5 years, which has contributed to improved patient outcomes. Similarly, from the days of the IVC delta and the IVC variability, we have now gone into the VEXUS mode, which is again probably an extension of fluid stewardship. From seeing when a patient is just fluid responsive, we are now using ultrasound to understand when a patient should not be given fluids. And this is where we look at the VEXUS as an integral part of fluid stewardship and hemodynamic optimization of your patients in the intensive care unit. When it comes to balanced salt solutions, you know from 2012 till a couple of years ago, there have been lots and lots of debates and publications happening to and forth. You can't put a finger and say balanced crystalloids are preferable in this particular subset of patients, but definitely in 2024, we realized that if patients are requiring more than the 30 mils per kilogram body fluid or ideal body weight of fluids, then probably you have to switch over from conventional crystalloids to balanced crystalloids, and that's been a significant paradigm shift that has happened in the last 5 years. If you remember the jigs of the first episode, it opened with a talk on oxygen targets in the intensive care unit, and it continued in the last couple of years with this iconic publication in the AJRCCM, which actually showed that conservative oxygen targets do not improve the outcomes in patients in intensive care unit. But if you look at it from a different perspective, you can see that the average PaO2 in the conservative oxygen arm ranged between 60 to 80, and in the liberal arm ranged between 80 to 100. And the Kaplan-Meier curves are actually hand in hand till the end. So conservative oxygen targets do not worsen the patient's situation or the clinical situation of the patient is a different perspective of the data which you can analyze from the iconic study. So do you put conservative oxygen targets for all patients? Maybe not. So you now know that certain categories of patients you should not be probably trying conservative oxygen targets. Who are they? The severe ARDS patients, the patients with traumatic brain injury, the pregnant lady at term. These are some of the focus groups where you cannot apply the conservative oxygen target groups, but all other groups probably you will probably be good good enough if you are managing the patient with a conservative oxygen target. Lot of oxygen, definitely not the norm anymore. When it comes to mechanical ventilation, we have progressed from the era when we were taught that 6 to 8 mils per kilogram ideal body weight is the good ventilatory target. Now we have gone to 4 or less into ultra low tidal volume strategy for lung protection. We are putting less emphasis on recruitment maneuvers. The futility of high PEEP has been accepted, and we don't go beyond 14 in current day practice in intensive care. We have progressed from believing only the driving pressure works to transpulmonary pressure driven setting of optimum PEEP, and of course lot of other applications for the transpulmonary pressure. And this is all got to do with the emergence of mechanical power, which we understood after the huge data which was accumulated during the COVID pandemic. Just to put into perspective, the driving pressure is now in everybody's armamentarium of numbers, not only because it is proven to have a guiding role in the setting of PEEP, but it also has an implication on mechanical power. And if you combine mechanical power and driving pressure, you have set yourself good targets for patients who should go on to early extracorporeal membrane oxygenation. And this is a paradigm shift that has happened in the last 5 years. So if you prone your patient and your driving pressure is more than 13 or 14, even though your oxygen may get better, these are patients who probably will ultimately end up on extracorporeal membrane oxygenation. So if you use this concept, you will actually have a different phenotypes of patients with the power, the driving pressure, and their compliance. You can actually phenotype these patients into different categories. Moving forward, the ultrasound. The evolution of ultrasound has been one of the major advances in the field of intensive care practice. In the 1990s, we were using ultrasound only for procedural guidance, a nerve block, for example, a vascular access, for example. But today, an assessment of a critically ill patient in the ICU is not complete without mentioning what the point of care ultrasound is telling you. And it is a dynamic entity, it is a point of care entity, and it is probably the most environment friendly entity of all the imaging modalities we have in our hands for assessment of patients with a varied manifestations of critical illnesses. So if you look at 2011, where we recognize the change in the clinical management by focus, we have now gone into 2024, where where some of the high-end ultrasound machines have actually got artificial intelligence and machine learning based algorithms built into it on how your lung ultrasound should be interpreted, how your echocardiogram should be interpreted, and how your VEXUS algorithm should be interpreted. It gives guidance to the operator what your next step should be. So that's where the change has happened in the use of point of care ultrasound, and these are all the areas where you can use ultrasound in the ICU. You can use it for cerebral perfusion, you can use it for cardiac activity, lung perfusion, you name it. Every single organ you can actually image in a replicable manner with the use of ultrasound. Two important areas where catheter-based therapies have changed the way therapeutic nihilism has taken a back step is in patients with acute ischemic stroke and in patients with major degree pulmonary thromboembolism. Those who have a relative contraindication for anticoagulation would have been denied thrombolytic therapy in the past. But with the advent of catheter-guided therapies, patients in shock, patients who are coagulopathic, patients who have relative contraindications for anticoagulation are still candidates for catheter-guided thrombectomy and thrombosuction, saving quite a few lives and salvaging quite a few right ventricles. Similarly, the timelines for intervention for acute ischemic stroke have gone forward from the 6 hours to 12 hours, now up to 24 hours with the use of judicious application of CT angiography, where you can identify those with salvageable ischemic penumbra and subject them to catheter-guided therapies with good functional outcomes among patients with ischemic stroke. Less is more concept has been discussed in intensive care. In the last 5 years, it has caught up in a lot of other areas. As we spoke, it's about fluids, it's about oxygen, but we also have talked about transfusion, sedation, duration of antimicrobial therapies, lesser use of X-rays in the ICU, and lesser calories for patients in shock. A thing about sedation, maybe when the JICS comes around in 2026, we'll talk about the advanced use of inhalational sedation in patients in the intensive care unit. That will be a major paradigm shift. It's already coming into some areas in intensive care practice, but definitely you will see less of intravenous sedation and more of inhalational sedation coming into our practice. Extracorporeal therapies have been always around in intensive care with pros and cons, with people arguing in and for and against, but plasma exchange in this country at least is going to play a major role. You get patients with a lot of poisonings, right, who may not be candidates for a transplant. You can use plasma exchange as bridge. You can use plasma exchange as destination, and you can use plasma exchange as support. So the re-emergence of plasma exchange, in my perspective, has been a change that has happened in the 5 years for the betterment of patients who probably are not candidates or cannot afford hepatic transplant. Similarly, the use of assist devices, the right ventricular and left ventricular assist devices as therapy, as bridge, and as well as implantable destinations are probably one change which has made the life of patients with end-stage heart disease something they can look forward to, that they can extend their life. All this fits into the concept of extracorporeal organ support, which is now an integral part of critical care learning and integral part of critical care interventions. Some of the old interventions which we were taught when we were doing our post-graduation 25 years ago have come back into practice. Nothing more spectacular come back than the capillary refill time. Our teachers way back in 2000 used to teach us to look at capillary refill time, and we used to think they were old-fashioned. And we are now back into looking at capillary refill time as an acceptable surrogate for lactate clearance in the ICU. Central venous pressure, frowned upon and buried in hemodynamic monitoring, is probably going to come back into ICU as a marker for RV dysfunction in patients with ARDS whose PEEP is actually causing RV dysfunction in an attempt to produce right ventricular protective ventilatory strategy. Another drug which has been in cardiothoracic intensive care for a long, long time is slowly coming back into mainstream intensive care practice. A lot of randomized controlled trials going on at this point of time across the world. That is the use of methylene blue in patients with vasopressor refractory septic shock. We have come back into the era of perfusion pressure. So Just like cerebral perfusion pressure, we have a coronary perfusion pressure, we have an abdominal perfusion pressure, we have a renal perfusion pressure. That will going to be the focus of hemodynamic optimization in the coming few years. Phenotypes of several important paradigms in ICU have been identified. We know that there are distinct phenotypes of sepsis, distinct phenotypes of AKI, traumatic brain injury, cardiogenic shock, and ARDS. An understanding of this with personalized prescription is probably the change we are going to see in the years to come. In the end, what else can be done? We should probably have more personalized prescriptions than stick to guidelines with a fixed mentality. We probably, in order to achieve this, probably adopting EMR should be a major paradigm, mental paradigm shift. We should all accept it. We should contribute to large data analysis, and this country has the scope to give the largest data for machine learning and data science algorithms for common situations, which will improve a lot of clinical situations. So with that, I would like to end my talk and invite you all for, it's not showing up, but this is the Kochi conference. Please meet, we'll all meet again in Kochi in a few months' time. Thank you very much.
Thank you, Dr. Srinivas. I think we will take all the questions at the last. Thank you.
Thank you.
Third talk of this session is post-ICU syndromes, the hidden burden. I invite Dr. Ramesh K.N. He is the head of the Department of Critical Care Medicine, Continental Hospital, and his survey on violence on doctors, burnout syndromes in the ICU, neurozonology, ECMO, and infectious disease, transplant medicine is his areas of interest. Dr. Ramesh K.N., please welcome post-ICU syndromes, the hidden burden.
Thank you, sir. Thank you for the kind introduction. And so today's my talk is post-ICU syndrome. So why we need to know about why a post-ICU syndrome? Because almost 50% of the patients who are getting discharged from our ICU are suffering from post-ICU syndrome. Basically, what does it mean? So any new onset or worsening of any following domains of functioning after discharge of the patient from critical illness, either it can be cognitive function or it can be psychiatric or physical function. So what are the main risk factors and what is the prevalence of this post-ICU syndrome? So according to our recent Japanese PACS study, it has shown that almost 50% of the patients who are getting discharged from the ICU are suffering from PACS syndrome for one domain, and if it is for two domain involvement, if it is almost around 20 to 30% of the patients are involved suffering from PACS syndrome. And what are the risk factors of PACS? So this is that study. So mainly more number of days stay in the ICU are more prone for PACS, and more sicker the patient in terms of Apache or SOFA score is more prone for PACS. And patients with elderly age group, pre-existing psychiatric illness or delirium, who has an episode of delirium in the ICU, or who has high intake of like use of sedative medications like benzodiazepines, all these are risk factors for PACS. So what are there in our hands? Like what are the modifiable risk factors? Like better to avoid sedation, deeper sedations, keep the patients in the lighter plane of sedation, like Richmond's modified Richmond scale of 0 to -1, and management of delirium, addressing the pain. So pain is one of the main risk factors, so addressing the pain properly with an analgesic or opiate analgesic. Avoid hyperglycemia, and so other potentially modifiable risk factors, like if the patients have reducing the length of stay by major interventions, early source control, early antibiotics, and early intervention, so that the length of stay in the hospital will come down, and other like addressing the shock early. So is it different from elective versus the emergency surgeries? Yes, it is definitely more common in emergency surgeries or urgent surgeries compared to elective surgeries, as shown in this figure. All the parameters like fatigue, depressive symptoms, anxiety symptoms are more with emergency surgeries compared to the elective surgeries. So coming to ARDS, according to our ALTO study, which has studied around 698 patients, which has shown mild mental involvement and physical impairment in 22% of the cases, and moderate impairment in 39% of the cases, and severe involvement in 15% of the cases. So it also has shown no difference between the hypo and hyperinflammatory phenotypes of ARDS. So these are all the main clinical features what we see in different all the three domains, that is cognitive impairment, physical impairment, or psychiatric illness. So cognitive impairment occurs in almost 25% of the patient according to brain ICU study, in which it is almost correlating up to similar to almost moderate traumatic brain injury patients. The patients recovering from ICU with cognitive dysfunction is almost comparable with almost moderate traumatic brain injury patients in terms of cognitive dysfunction. So these are all the areas of cognitive dysfunction what we can see, that is attention, concentration, memory disturbances, mental processing, speed and executive functions. These are all the areas which are involved in cognitive dysfunction. And psychiatric illness, majorly we'll see anxiety, depression and post-traumatic stress disorder. Anxiety, more commonly patients may present with loss of appetite, restlessness, hyperirritability and fatigueness. And depression, they may present with poor appetite, loss of weight, fatigueness, loss of sense of hopelessness, all those things and all. Post-traumatic stress disorder, mainly it is an affective and behavioral response to the stimuli. For a past provocative stimulus like flashbacks, it can have a hyperarousal state or a panic attack type of thing. And physical impairment, these are all the main factors which will contribute to the physical impairment, like ICU-acquired weakness or the contracture of the joints which will cause restriction in the movement, or poor pulmonary functions, or malnutrition and post-sleep disturbances and all. So generalized weakness could be because of critical illness neuromyopathy, critical illness myopathy, or because of prolonged use of high dose of muscle relaxants. And contractures, what we can see in almost 34% of the patients who are coming out of the ICU, who are staying more than 14 days in the ICU, will suffer from some or the other joint problems or contractures. Most commonly, it is involved in the elbow and the ankle joint. Poor lung functions could be because of the lung pathology itself, or it can be because of the muscle weakness, or it can be because of the nutrition related problems. So why we are not able to diagnose and treat PACS in our ICU? What are the probable reasons why we are not able to pick it up? This could be because of lack of awareness among the patients and in the ICU intensivists also. And it could be because the discharge plan what we make is more organ specific, rather than we are not focusing on the PACS, what happens after discharge of the patient, and whether they are coming up for the follow-up or not. Even if they come for follow-up, whether they are coming and following with the primary consultant who does not know about the PACS and all. And so these are all the main reasons why we are not able to pick the PACS. And most of the times they may present with very minimal symptoms which may not be picked up until unless we focus on that. And there were no proper guidelines or the bundle to address this. This was a paper in 2019, but in 2020-21 we had an assessment guidelines by SSCM, which has proposed an assessment for cognitive, cognition, psychiatric illness, and then the physical impairment. So in which who are the patients who are to be screened? Like the patients who are having pre-existing cognitive dysfunction, patients who had a psychiatric illness, anxiety, depression and all previously, and patients who are physically impaired, disabled before coming to the ICU only. And during the stay of the ICU, when the patient has sick, like very high vasopressor supports, long stay on ventilator, or when the patient is having hypoxia, post-cardiac arrest. So these are all the patients who are at risk of developing a PACS. So these are the patients we have to evaluate or assess for PACS. So this assessment will start from the ICU, and after shifting from ICU to the ward, in the ward, and after discharge of the patient, pre-discharge and post-discharge of the patient also we have to assess. What are the assessment tools? For the cognitive assessment, we have Montreal Cognitive Assessment Tool, and for anxiety and depression, we have HAD score, that is Hospital Anxiety Depression Scale, and for post-traumatic stress disorder, we have Impact of Event Scale, Revised Scale, and all. And for physical function, 6-minute walk test, and Eurocall function and all. So cognitive dysfunction mainly will be assessing for memory assessment, concentration assessment, and ability to have an executive tool and all. So the score of less than 25 or 26 indicates mild cognitive dysfunction. Score of less than 18 indicates moderate to severe cognitive dysfunction. And psychiatric rating scale, it is mainly the hospital anxiety depression like HAD score what we tell, and we can also use Beck's depression inventory scale or Beck's anxiety inventory scale also. So for physical function assessment, we use 6-minute walk test, which is more effective, and for all the extubated patients, pulmonary function test can be advised. So always there is prevention is better than cure. We all know about the ABCDF bundle, just now we discussed in the previous talk. So this is the ICU liberation bundle what is proposed by the Society of Critical Care Medicine. So in which we have ABCDE. A means assessment of the pain, analgesia, assessment of the pain, delirium, and appropriate addressing of the pain, because that is the main risk factor for that. And then B is spontaneous awakening trial and spontaneous breathing trial. As early as possible, we have to mobilize the patient. Spontaneous breathing trials has to be started. Wean the patient as early as possible. Reduce the length of stay and length of mechanical ventilatory days. And C is choose the appropriate analgesia, opioid, avoid benzodiazepines, dexmedetomidine can be used. And then D is delirium management. Whenever the patient has delirium, appropriately manage the delirium, and because it is one of the main risk factors. And early mobilization, we'll speak about this one later, and family involvement. So most effective strategies are minimize the sedation, and then the priorities on the early physical rehabilitation of the patient. So this is about the ABCDF bundle, which has shown a lot of benefit in terms of reduction in the number of days on in the ICU and the hospital stay, and then it has also shown a survival benefit. It has shown that it will reduce the delirium incidence, post-traumatic stress disorder, and the need for restraints in the ICU. So it is recommended to keep the patient in Richmond's agitation Richmond scale of 0 to -1. So early ambulation, if the patient is hemodynamically stable, if the patient is on less FiO2 or PEEP requirement, then easily we can mobilize the patient on the bed. So, but when the patient is hemodynamically unstable, or when the patient is having a requirement of high FiO2 or high PEEP requirement, then that is where we are a bit worried about mobilizing the patient. So, but the studies, the evidence shows that there is definitely there is a benefit with early ambulation therapy or early mobilization, either on the bed or onto the chair mobilization and all. But there are few recent studies like in 2022 meta-analysis, and then recent 2 randomized studies, randomized controls trials, which has shown that the beneficial effects are there, but it comes with the cost of adverse events also, like desaturation, tachycardia, all those things and all. So on the ICU diaries, I think we have discussed this one previously also. Family is allowed to record the events which has happened in the ICU during the stay of the ICU, which will also help the patients to recover from their memory, and then it also reduces the post-traumatic stress disorder. Treatment is mainly addressing each domain separately, cognitive dysfunction, psychiatric illness, and then the physical impairment. So these are the impact of this PACS on quality of life of the patient. Work, they may not go, 1/3 may not go back to their work, and then they have problems with the social interactions and all. And they have financial implications. This is PACS family, the acute and chronic psychological morbidity of the patient's family because of the sickness of the patient and then the death of the patient, what they suffer. These are all the various risk factors for the PACS family. That is, if there is a death of the patient, or if the patient is very younger age group of the patient or the family. Financial burden. So it can also be addressed by PACS clinic. It is advisable to have a PACS clinic in all of your clinical practice, so that we can address all the domains of PACS with the multidisciplinary involvement of psychiatrist, physiatrist, and then the physiotherapist. So the prognosis wise, cognitive dysfunction and the psychiatric illness will take a long time for the recovery, minimum 6 to 12 months. Usually it will persist for.
Dr. Ramesh.
Yeah, done, sir. It is the last slide. Yeah, this is so it will persist for more number of years. And physical impairment, usually it recovers. Rate of improvement is slow with polyneuropathy. Thank you.
Thank you, Dr. Ramesh.
I'd like to thank organizers of the JICS for this opportunity. Thank you.
Thank you. Next talk is about microbiome in ICU, the forgotten organ. I invite Dr. Vivekanandan P. Dr. Vivekanandan is a consultant intensivist, Royal Care Super Specialty Hospital, Coimbatore. He is a consultant intensivist since 2008, worked in various hospitals in UK and India. His areas of interest is teaching and training. I invite Dr. Vivekanand for the talk, microbiome in ICU.
Thank you. Thank you for the invite. Good afternoon to one and all. The talk would emphasize on knowing about the forgotten organ, the microbiome, the critical illness and what the dysbiosis is all about, what are the therapeutic options, and what the current guidance is. Who are we? I think probably as the adage goes, I think it is what we eat. So I think the microbiome is developing as we evolve, starting from the birth. I think whenever we are born by a natural birth or by a cesarean section, definitely there is a change in the microbial invasion of the microbiome inside us. So it's quite different to how we evolve over the years. And it is important to note that the intestine is one of the organs out of all this that is going to evolve every 2 to 4 days. So I think the microbiome, which is going to change every time, that's going to have a huge impact on a day-to-day basis. So it's important to note that as well. And we are all of different types, and if you're going to take these 3 different types, which a majority of us are, Prevolotella, that is the type of enterotype that we belong to if you're going to eat more of fruits and vegetables. And if it's going to be a Bacteroid type, then we are probably relying on more of protein diet or a fat diet or more of a fast food kind of diet. Ruminaceous, probably Ruminococcasia, is the type of enterotype where somebody relies on more of a resistant starch. So these are the 3 main enterotypes that we belong to. And what does it tell you? If you're going to be on the Prevolotella type, then probably we have got a much more richness, the alpha diversity that is being talked about, where the number of species that we tend to have is much more, and that is going to keep a healthy domain within the microbiome. But whereas Bacteroids is going to have a less richness, and probably that is going to lead to a more of a metabolic syndromes, be it diabetes or any other. And what are the benefits that we have from the microbiota? Probably there is this phenomenon called the colonization resistance. So it tends to keep the pathogenic bacteria quite low, and the immune dysfunction is both locally and systemically is well maintained, and also the metabolites that are being produced by these biomes are going to make a huge varied effects, not only in the gut but also systemically. Collination resistance by the microbiota is through the fatty acids. They are typically short chains and typically less than 6 carbons. And these are two things that one needs to make a note of. The antibiotic, which is being produced by the microbiota, is going to keep the VRE growth down. We know this from hematopoietic stem cell recipients. And also the Bacteroides fragilis, which is part of the microbiome, is going to produce the capsular polysaccharide A, and that is a potent immunological homeostasis maintaining agent. What about other metabolites? We have got this short chain fatty acids. They tend to alleviate inflammation, modulate immunity, and it has got extensive effects other than the gut, quite all around the different organ systems. Butyrate is a fuel for the goblet cell, which maintains the mucus, and the propionate tends to reduce the inflammation and IgA production as well. How about acetates? They play an important role in reducing the inflammation in the lungs. They play a huge part in reducing the acute lung injury and in ARDS. And the same thing holds good for reducing the severity of sepsis as well. It is the acetate, which is a short-chain fatty acid, that's going to be useful in that. Flavonoid metabolites, huge variety of effects, and they tend to keep the viral and bacterial infections at bay. This particular slide, I think, emphasizes that they are not only acting at the gut, but also at different organ systems as well. And my point is just we need to make a note of this muscles, which, like the previous talk, where the post-ICU care, quite a few of them detrimental with a deranged muscle function. All these things do have an impact on every other organ systems. So I think we need to take care of the microbiome to a greater extent. So coming to dysbiosis, critical illness and dysbiosis. In ICU, I think dysbiosis can set in as early as 6 hours. And this picture tells you in a healthy gut and in a diseased gut, there is going to be a translocation of the gram-negatives, staphylococcal, enterobacteria, and going into cause increased inflammatory markers and causing organ dysfunction. What is the risk factors for dysbiosis? We very well know people in ICU, at least 79% of them easily can have antibiotics be it preventive or therapeutic. And then gut dysmotility tends to happen at least in 60% of them. And all these interventions are going to increase the chances of dysbiosis. And hospital-acquired infections is an entity that is going to evolve soon after that. And because of the translocation, if you have got any doubt, then probably there is enough experimental data telling you that the bacteria in the gut, which is measured by the metagenomic assembled genome, is in par with what the bug that is going to be cultured through the bloodstream. So both of them were not varying from each other. So that is a foolproof that there is a gut translocation that is happening and that is causing the bloodstream infections. Apart from gut, what else happens? The airway also tends to have dysbiosis. And all these crosstalks tend to happen. I'm sure most of you are aware of the gut-lung axis, where one of the parameters, the microbial metabolite, the D-aminotyrosin, has been shown to reduce the influenza impact. So that's a foolproof. How about gut-brain axis? Many of us are very familiar with this, that cirrhotic patients, the ammonia increase can cause cerebral edema, and we do rely on non-absorbable antibiotic, the rifaximin, and the non-absorbable disaccharide, which is the lactulose. How about the heart? Yes, the toxic metabolite from dysbiosis is going to cause heart failure. Inflammation is going to cause acute heart failure as well. The key adverse effects, there is going to be a multi-organ failure, and hospital-acquired infection is going to increase the mortality. What are the therapeutic options available? Well, the fecal microbiota transplant, selective digestive decontamination, which we will debate about tomorrow, and the microbiome-directed therapies as well. Quickly going through selective digestive decontamination, it's a standard of therapy in Netherlands, but it hasn't taken up elsewhere, but the studies over there show that there is reduced mortality. And this trial, which was very well conducted as a crossover randomized control trial, showed there is a mortality benefit. However, it is non-significant statistically, but with a posterior probability of 99%, it is of moderate evidence. And this is what exactly they did. There was a oral paste, gastric suspension, and the intravenous systemic therapy as well. And the meta-analysis later on, which was done, did show in JAMA 2022 that there is a reduced risk of VAP and ICU-acquired bacteremia. Cochrane reviews, what do they say? Well, if you're going to use a topical prophylaxis, then there is a reduced respiratory infections, but if you're going to use topical and systemic, then there is a mortality benefit as well. And how about fecal microbiota transplants? Well, we have got the highlighted conditions where it can be useful, the critically ill with antibiotic-associated diarrhea, and in septic shock. And I wanted to emphasize the fact that in severe alcoholic hepatitis, Jadeja et al. Did prove that even on a lighter note, people get de-addicted as well. So the gut-brain axis seems to have a role there. Just make a note. And although it has been much talked about, the RCTs are lacking there. Well, we have got a well-defined role in resistant Clostridium difficile severe infection where the mortality with the surgery is going to be very high. So that probably is one of the clinical situations where you can rely on. Critically ill inflammatory bowel disease patients in critical in ICU, well, it has got a role, but it is not as similar to C. diff pathology is. It can be useful to eliminate multi-drug resistant organisms if all other options are ruled out. And the ESPN with the meta-analysis showing that there is a favorable outcome of probiotic and symbiotic in VAP is something to note about. And this is in a nutshell what these therapeutic options can do. And yes, there are limitations. There is lack of RCTs for FMT. For SDD, there is lack of data in centers of high resistance like us. And for symbiotics, probiotics, metabolites, we don't know the exact dose and where exactly to give. So the current guidelines go through the fecal microbial transplantation where it does detail from 2002 onwards. In recurrent Clostridium difficile, we can use it. Fecal spores can be used. It will be through the capsules. And then live microbiota as a single rectal therapy can be done. And the recommended routes has been very well defined, and the bowel preparation of having given the antibiotics to treat it and then you need to give around 2 to 4 days is what the recommendation says. How about Cochrane recommendations on probiotics? Probably very little effect if at all, and the number needed to treat is much high. And if you are going to reduce the VAP incidence, the quality of evidence is very low to low. And how about patients undergoing liver transplant, and if you had to go use prebiotics and the probiotics? Well, again, the evidence is a little bit low. Definitely, there is no mortality benefit. And how about in pancreatitis? We all know that the ProPatriata 2004 trial did show increased mortality, and we are not using it because there is a straightaway access for these live organisms into the system. And what does the translational research, if it were to tell us what to be used from the research to the bedside? Well, the doses are not very delineated. The toxicity profile has been much talked about. Yes, it's a possibility. Clear directions are not available. Which particular illness will need which therapy is not very clear about, and we need to have a personalized microbiota therapy. And if we were to go for it, then we need microbiota-based biomarkers, which will tell what exact type of microbiota we are dealing with to use it for a personalized medicine. And we need to stratify patients accordingly, and only well-designed clinical trials will give us an answer. So this is something that's available to the general public. Anybody can walk into a clinic and then get this microbiome testing done. That will tell you what type of organisms are dwelling in and what type of diseases we are more prone for. I think we need to have a more emphasis on keeping the biome healthy, and FMT we know has got emerging roles, and it has got a role even in Parkinson's disease, and multitude of other specialties are very interested in. And SDD, definitely we need further evidence within our context where there is high microbial resistance. Thank you.
Thank you, Dr. Vivekanandan. We'll move on to the next topic, the promise of personalized medicine in ICU. I invite Dr. Raman Muralitharan. Dr. Raman Muralitharan is a senior consultant in critical medicine in Baby Memorial Hospital in Calicut. His academic achievements are 7 national and 1 international, authored a chapter in 1001 MCQs. And special interest is humanizing intensive care, resuscitation and hemodynamic monitoring, and difficult liberation from ventilation. Dr. Raman Muralidharan.
Promises of personalized medicine, that's what given to me for the JIGS presentation. This was me a couple of months ago when I received a faculty invite from JIGS. I was a bit confused and puzzled like this after reading this topic. When we think of personalized medicine, the first thing come to our mind is we think of providing careful matching over your patient's biology to your medical care. We have been using it beautifully in cancer care for targeted therapy by making use of genomic technology of patient as well as the disease. I started thinking about how to proceed with this presentation. Should I add ARDS phenotyping? We know about it, and COVID phenotyping we are very familiar, and sepsis is coming up. So I made an SOS call to my geneticist colleague and to get some insight. I got some. I started working on that, and I'm going to share those thoughts with you. Plenty of gratitude to Pradeep and Ajit for giving me this opportunity and podium for the next 10 minutes. And no disclosures because I'm not linked to any of this kind previously. And all these presentations are based on readings and other updated evidences. I couldn't find any RCTs, all are on retrospective evidences based on cluster analysis and single center experiences. Leave that behind. Just imagine, only one size of shoe is available on earth. In this world of heterogeneity, you can see plenty of people with different faces and different foot sizes, having various foot sizes. And if you apply one size fit all policy, it will beautifully suit like this, and some will walk like this, and some won't enter into your eyes. Is it good or bad? I'm asking you. I know the question is big no from you. And let us translate one size fit all policy from the cement bench to the bedside, or from this room to the bedside. Are we doing it or not? This is a virtual vignette, and a 70-year-old man, tablet-controlled diabetes mellitus and hypertension, is to travel to Munnar, and a 1-week fever, high grade, and a cough without expectoration, worsening dyspnea and confused, and reported to ER. ER physician diagnosed him as a case of community acquired pneumonia. As per syndromic approach, we usually follows that. Stratified the case using different scoring systems like Muse, Curve, 65, SOFA, Apache 2 as a screening tool, and to decide on cytocare to assess the severity, prognosis, and outcome. Investigations were sent as a part of protocolized medicine, which all are evidence-based. Blood routine, culture, CRP, procalcitonin, and so on and so forth. And it's again fitting into the one-size-fits-all policy. The ER physician is following that. They are still at the stage of one-size-fits-all, and we need some more stratification to get a stratified medicine and some more personalization to get the precision medicine at the end. Where are we now? The patient is being shifted to ICU. B intensive care physician treats syndromes of the heterogeneous patients with the common symptoms and signs, include them in the same diagnosis and treat them with the same prescription, and some will improve, some won't, and some will get harmed. At times, some of us, while moving along the syndromic approach, send markers, pyruvate, lactate, IL-6 and cultures, some personalization using genotyping of the bacteria, sticking on to one-size-fits-all policy. We are still at the proteome level. To go further, climbing the ladder, we need precision medicine rather than personalized medicine. When the treatment, what is precision medicine and what is personalized medicine? When treatment prioritizes patient needs and preferences based on biomarkers and clinical features, it is that personalized medicine. When the treatment is optimized on genetics, it is called precision medicine. Some might use it as interchangeably, but there are some morphing recently happening in this case. To achieve this, to identify the right patient, right drug and right dose, right route and right time. That's what the concept is. When we think of promises of personalized medicine, the first thing come to our mind is regarding gene and its regulation. Exactly a month ago, these two scientists, Victor Ambrose and Gary Rukin, two American scientists, have been awarded with the Nobel Prize for medicine for their work on gene regulation. So we all are aware that there is so much of exciting research happening in this era at the bench. Not seen reflected to the bedside, we all are cool, composed, and nothing exciting happening there. How can we make it better? By adding some excitement here. To go beyond our current care practices from the proteome level to the genome level, we have to incorporate these components of precision medicine there. Genomics, transcriptomics, proteomics, metabolomics, immunomics, and microbiomics to achieve this dream of precision medicine. If you focus on the molecular basis of omics technologies, it's essentially the precision medicine is application of the omics technology in sepsis. I will focus from here onwards, I will shift my gears down and please focus on this, focus on sepsis, pathogen, they produce spam, and endotoxin will be released. If you study on this, it is called microbiolomics, and host will produce some amount of damp and changes in DNA. That changes in DNA is described as genomics, and changes in RNA is called as proteomics or transcriptomics, and the cells produce some changes, it's called metabolomics, and T cell changes occurs, it is called immunomics. The cocktail of this is called omics technology. I'll come to genomics, the study of gene and its function focusing on DNA. The gene polymorphism happens only in the case of less than 1% population, forming allele variations in the DNA, not amounting to mutation. Leads to upregulation of inflammatory markers, HLA-D for expression in the dendritic cells, and this can predict the severity and outcome in sepsis. When it comes to the epigenomics, if your focus is shifting from DNA to the RNA part of the DNA without changing DNA sequence due to environment or disease, there will be upregulation of IL-6 and IL-10. We were using it in the COVID era, and there will be downregulation of IL-7 and IL-15, which is a useful interleukin and predicts deterioration and outcome by measuring it quantitatively. It can be done. Now I will be shifting to the proteomics, the study of proteins expressed from genome reacting to the environment as well as disease, and it's very sensitive and specific, extensively studied in sepsis and COVID ARDS. Upregulation of STREM as well as IL-3, IL-6, vimentin and peptides, and quantification of them is very difficult. Peptides, patient evolution, predicts evolution by deep phenotyping. Transcriptomics is an upcoming field, so there is study of mRNA. That is mostly studied miRNA 133 was studied deeply in the case of sepsis, for sepsis deep phenotyping. And this is all called SRS1 and SRS2. These are the two phenotypings, deep phenotyping. SRS1 is immunosuppressed and SRS2 is immunocompetent. It detects earlier than the biomarkers so that we can separate or differentiate between SIRS and sepsis. Metabolomics, we are using it as lactate and pyruvate, and if you can measure the LPC to assess severity, it also differentiates between SIRS and sepsis. Endotoxin, we have been using many filters for a long, and even though there are evidences are minimal, even endotoxin assay is difficult. If you can assess it, you can use these filters, polymyxin hemofilters or hemabsorption filters to do that. Immunomics, study of immunoglobulin. Dysregulation of the immune system produces decrease in the immunoglobulins due to T cell exhaustion, and quantification of immunoglobulins and interferon gamma is in the vogue. Monitoring PD-1, that is programmed cell death receptors, and HLA-DR receptors also predicts about the severity and outcome of the disease, usually in sepsis. Sometimes resulting in immune paralysis, it's also called immunosenescence, occurs later in the sepsis and after the hyperinflammatory state. 30% death occurs in this phase due to decreased HLA-D4 expression. Could be measured using flow cytometry, IgM, IgG, enriched polyclonal immunoglobulins, and GM-CSF may be useful to counter this situation. There is no recommendation for that. Now, it's all about detail. It's all about omics-based biomarkers. The conclusion is omics-based biomarkers are the future. HLA-D4 program cell death receptors, 2B for CD160, HMG, B1, and IL-6 and IL-17 and IL-7 and 15, endotoxin and immunoglobulins. Incorporating these omics-based biomarkers into bioinformatics. Bioinformatics is divided into four sessions. One is health informatics, another one is clinical informatics, and third is biomedical informatics, and nursing informatics also comes. The cocktail of this, including scoring system, new biomarker data, electronic health records, and patient trajectories, gives us a deep phenotyping of the sepsis as well as ARDS so that you can go ahead with the advanced treatment. These are the applications of precision medicine, genetic syndromes in pediatrics. We are into that. Target therapies in oncology. In sepsis and ARDS, it's diagnosis and treatment. Drug delivery using RNA, coupling with the nanoparticles, and many more are happening at the scientist level at the bench. The limitations are data privacy concerns of sensitive data, risk of unequal treatment strategy, absence of insurance, so that increased out-of-pocket expenditure, need for high-performance hospital information system, and specialized training for healthcare worker, need collaboration with the geneticist. Legal loops, absence of regulation, concerns of patient safety, worries about data security, ownership of AI decisions, and legal threats to AI errors. Takeaway thoughts include going to be the future, revolutionizing the sepsis and ARDS management, improving diagnostics using real-time data analysis, incorporating new gen biomarkers, bringing in targeted therapy with refined big data, and providing more data privacy. I'm sorry, it is not simple at all to achieve this, because we lack this kind of person in our country, and we won't be able to get that care translated to this population, making it more equitable. Promises it will be worth wait. We promise it will be worth wait. No need to worry, it is almost there, around the corner, though difficult.
Thank you, Dr. Raman Muralidharan. An interesting talk. I opened this session for discussion with the limitation of time. I think we'll maximum 5 minutes. I think we can give. Thank you.
Any questions from audience for all the speakers?
Good afternoon, sir. All the sessions were good. I have a doubt, sir. I think it should be directed to Vivekanandan, sir, but any of you can answer. So there was a concept set by sir, SDD. Only topical antibiotics, some outcome benefits is what the sir said, but topical plus systemic antibiotics, he says there's some mortality benefit. So can any of you elaborate on that, sir? Like systemic, and what about antibiotic stewardship? I'm not able to understand that part, sir. Like selective digestive tract decontamination, topical plus systemic antibiotics. Something sir said that there's mortality benefit.
This question is directed to which speaker?
Dr. Vivekanandan.
I request all the speakers to come on to the stage. Dr. Bilina Chako, Dr. Srinivas Samvedam, Dr. Ramesh Kain, Dr. Vivekanathan PM, Dr. Raman Muralidharan.
The context of SDD was with regard to the topical applications of antimicrobials and the systemic IV antibiotic, which is given typically for 4 days. So it is with relation to that the topical component of it and the systemic component of it. And the systemic component will typically be for 4 days as per the regime. And if one were to use both of them, then the mortality benefit was observed. But if it is just the topical application that was used to the oropharynx and the gut, then the reduction in respiratory infections was only observed. So that's what I meant with that slide.
Thank you, sir. Thank you, sir.
One question to Srinivas, sir. Srinivas, sir, just I want to know, recruitment maneuvers are almost nowadays not to be done. Recruitment maneuvers. So now when to be done and which cases?
So
Can't hear.
So, as you said, there's a lot of evidence that has accumulated that repeated recruitment maneuvers for all patients may actually cause more harm than benefit. So, if you have somebody whom you are finding it difficult to achieve the target VF ratios within the normal driving pressures, a single recruitment maneuver can be attempted with appropriate hemodynamic monitoring, but not for all comers in ARDS. You have to pick and choose your patients for that. But evidence is building up against the use of recruitment.
And sir, role of RI in knowing the acute kidney injury, as you were talking about the VEXUS. So how effective it is?
Role of?
In acute kidney injury, RI, you do the RI, sir? RI index?
Resistivity index.
Yes, sir.
Yeah, so these are two different aspects of renal protection. One is the VEXUS score versus the resistivity index. But the most important thing is if you can estimate the renal diastolic pressure with the use of sonography, that will help you to understand the renal perfusion pressure. So the renal perfusion pressure is the one that is going to tell you whether your GFR is actually going to dwindle or your resuscitation strategies are perfusing the end organ or not.
One more question to sir, I just forgot the name. Role of probiotics in preventing the VAP.
I think the probiotics has been used quite extensively. There are loads of papers on it, but the Cochrane review, if you were to give a simple answer, there is no benefit. The quality of evidence is very low. So there are many papers to suggest, yes, it can be beneficial. And one of the meta-analysis, which is published by the ESPEN, that suggests there is a favorable outcome with probiotics for prevention of VAP. So it's a mixed picture. But if you're going to rely on some of the guidances, especially Cochrane review, then probably the quality of evidence is very low.